Should I start, sir? Please. At the outset, I'd like to say I have no financial disclosures related to this presentation. So the question is, are we indeed smiling through our lenticule surgeries? Well, there have been certain issues like slower visual recovery, issues with centration and with toric alignment, surgical learning curve, and of course the ocular surface. So there have been various reasons why this has not been completely taken care of with existing lenticule platforms. However, this has been improving with all the later iterations of these machines. With this in mind, we wanted to think of our research question: can we overcome these challenges with new lenticule extraction platform? So this is a paper published by Dr. Mahipal's group. This uses the ELITA platform, which the highlights of this are a low energy treatment, minimal spot separation, which makes the ease of lenticule dissection much more, less keratocyte activation, and the biconvex lenticule shape that matches the anterior and posterior surfaces better and therefore causes less Bowman's distortions and less impact on quality of vision. The aim of our study was to analyze visual outcomes, quality of vision, and ocular surface in this new lenticule extraction procedure. We included 105 eyes with spheres less than 8 diopters and cylinders less than 4 diopters. We did the evaluation for dry eye on Schirmer's, TBUT, keratograph, and LipiView. We used our novel thermography device to look at the ocular surface, and we looked at aberrations using the eye trace system. We looked at our follow-up data for uncorrected and corrected visual acuity, aberrations, and contrast. So coming to our results, the efficacy and safety was found to be very good. Over 95% of patients in these 105 eyes achieved 20/20 or better. No eye lost more than 2 lines of vision. One eye had lost one line of vision because of an epithelial defect. The accuracy, as you can see in the plot of the spherical equivalent attempted versus achieved, was very good. Initial iteration showed a slight undercorrection, which was taken care of later on. In terms of the refractive accuracy, within 0.5 diopters on the autorefractometer, 66% of eyes achieved this, and within a diopter, 90% of eyes achieved that kind of accuracy. In terms of astigmatic corrections, we achieved an accuracy in greater than 75% within a half a diopter and greater than 97% within a diopter of the attempted correction. In terms of faster visual recovery, we can see that there's a reasonably good visual recovery on day 1. What you can see is that it's about 0.1 in terms of Snellen equivalent, which is a pretty good visual acuity, which was maintained at day 7. We also looked at the percentage of eyes achieving 6.6. 82% on day 1 achieved 6.6, and 96% achieved 6.9. In terms of learning curve eyes, in the later eyes that we did, our uncorrected vision was almost 6.6 in majority of eyes on day 1. The Holiday EKR report shows a well-centered ablation in these, showing that you can center the treatment well. In terms of the aberrometry data, we showed no significant increase in aberrations, and a trend towards a decrease in the spherical aberration was noted in these eyes. As you can see, this is a representation from the eye trace system. In terms of contrast sensitivity, it was found to be, there was a slight reduction which was not statistically significant, and this was found to be better than the 40% at 10 cycles per degree, which is a good contrast maintained post-surgery. In terms of our dry eye data, the lipid layer thickness and non-contact TBUT also did not show any worsening. In fact, it seemed to be slightly better. And our thermography device, as you can see, we did a small study comparing lenticule and flap and found it to be better in the lenticule group. The limitations were larger sample sizes needed, long-term follow-up of data is needed, and assessing outcomes in low, moderate, and high myopes separately is needed. To conclude, with this new system, we have a faster visual recovery, toric alignment is possible, the ocular surface is well preserved, there's better centration with less aberration, and a shorter learning curve. Thank you.
Thank you, Dr. Rohit. If there is any question on, did you compare with any other method like SMILE and all, any, and found any difference?
We don't have two platforms. I can't directly compare with SMILE. So this is our initial data. We were one of the sites that did the limited markets release for this as well. So this is our initial data that we've got. I am trying to do a comparison between flap and this, but I don't have access to another lenticule platform to do a direct head-to-head comparison.
Any specific complications seen with this system, with this platform?
So the good thing is that suction loss is virtually non-existent in this platform. We did have cap tears, as you can have initially. So there was a initial, like I showed the learning curve, we did have 2 eyes with cap tears, one of which extended a little centrally as well. On the whole, dark spots were not noticed except in one eye where we had difficult dissection, which was quite prolonged. We didn't have any retained lenticules or anything like that, but there was a prolonged dissection time in that particular eye and a slower visual recovery.
Is there any study by Maipan and all?
Sorry, sir? So I think Raghav is the best person. He's probably going to present that. But I think their data and ours is fairly similar. I think that's what you're going to present. But the visual acuities, I think the data published was on visual acuities, not on aberrations specifically. But there was good, there was quick recovery of vision in these eyes.
These are the machines used, I think, very recently. Maipan started about a year back.
So I think Center for Sight, again, Raghav would be able to answer better, probably started the studies in 2019 or 2018.
And what about you?
We started this in 22 April, sir.
Okay.
Sorry, 23 April.
23 April.
Yeah.
Your post-op refraction was on, what you presented was on auto-ref
Yeah,
readings.
so that was on the auto-ref.
Was a subjective correlation also done in those cases?
So subjectively, I mean, a lot of those eyes were 6/6, but they were showing refractive error. So in fact, AR is not the best way to do it. That is a limitation. But then again, practically in refractive patients to do a subjective.
Did you try doing it with the retinoscopy?
We tried it in a few eyes initially, but again, doing that for a large subset is difficult.
Do you go for any little bit hypercorrection or
So
normal?
just now the nomogram provided automatically boosts a little bit, so it does do that on its own. We are not doing anything outside the nomogram which has been provided by the
so
company.
as per nomogram only?
Yes.
Okay.
Yes, sir.
Thank you very much.
The early results presented here were much better than the previous platforms. So do you think that is basically because of the biconvex nature of the lenticule, or there's some other role to play, or the lower energy which is...
So I think it's the lower energy probably. The aberration data may be related to the biconvex shape. Again, I think the NN group is doing stuff on the subbasal nerve plexus being better maintained. So I didn't have time to go through the thermography in detail, but for patients with neuropathic pain, we've looked at thermography, even in just normal patients, and we found that to correlate well with pain scores in patients who have normal Schirmer's and T-bar. And in this, we found a very good preservation of the ocular surface on that thermography device, along with the lipid layer and non-contact TBOT.
Thank you. Very good presentation.
Thank you, sir.
We go to the second speaker, Dr. Utkarsh Dwivedi. Is there? Dr. Utkarsh.
You can.
Huh? Utkarsh? No, not there. Okay. Then we go on the next, Dr. Surbi. Dr. Surbi is there?
No, I think you're seeing the second page.
Huh? Oh, sorry.
Just 2 seconds. Diksha Rani.
Yeah, Diksha. Dr. Diksha is there? Yeah, she's going to talk about topo-guided versus WFO LASIK for correction of myopia and compound myopic astigmatism. अच्छा वो absent है.
Good afternoon, everyone. I'm Dr. Diksha. I'll be presenting on clinical outcomes of topography-guided versus wavefront optimized LASIK for correction of myopia and compound myopic astigmatism on Zeiss MEL 90. So in the past, topography-guided treatment has been used for irregular corneas, past decentralized ablation and smoothing of interior surface, whereas the recent evidence has shown its efficacy on normal corneas as well. So we use MEL 90 system for this treatment, where patients' eyes imaged and analyzed using unique elevation points in cornea. The data is then transferred data is analyzed at CRS master, and the customized ablation profiles are created on MEL 90 or MEL 80. The MEL 90 has recently introduced a AAA LASIK, that is advanced ablation algorithm, which provides a single ablation profile for wide range of sphere and cylindrical corrections. So we conducted a study comparing the AAA platform of MEL 90 versus the topo-guided treatment of the same. So we included 60 eyes which underwent topo-guided LASIK and 90 eyes which underwent AAA LASIK between January 2021 to September 2022. All the patients who were eligible for surgery and all the means were included. The flap thickness was 100 and the hinge position was superior. The preoperative parameters in both the groups were comparable in all the categories. So coming to the intraoperative parameters, while the ablation depth and diameter was similar in both, the ablation duration was higher in topo-guided group. This may be associated with a lower degree of patient cooperation during the surgery, and the difference in MEL 90 is because the topo-guided platform of MEL 90 fires at a lower frequency of 250 Hz in contrast to 500 Hz of the AAA LASIK. So coming to visual outcomes, more than 100% of the patients in both the groups achieved a UDV of more than 6/9, while more than 80% achieved a vision of more than 6/6. The complications in both the groups were similar. So here we can see that the post-op uncorrected distance visual acuity was comparable to the pre-op corrected distance visual acuity in almost all the patients. Around 8% of the patients gained 1 line in topo-guided group. The target refraction, the target correction was similar to the pre-op target, and around 95% of patients were within plus minus 0.5 diopters of the post-operative refraction, and this remained stable over 6 months. The results were similar in AAA LASIK, with 13% patients gaining 1 line, and 96% of them were within plus minus 0.5 diopters. So coming to higher order aberration profile, the total higher order aberration was similar in both the groups. Spherical aberration was slightly higher in the AAA LASIK group, but the difference was statistically insignificant. The coma was higher in topo-guided group, again maybe because of the vertical movements of the patients due to longer duration, while the spherical aberration was similar in both the groups. However, there was no statistically significant difference in any of these. So to conclude, AAA LASIK on MEL 90 imparts a highly safe and efficacious means of refractive correction of myopia and compound myopic astigmatism with visual outcomes and higher order aberration profile comparable to the topo-guided treatment. And however, the limitations are small sample size and retrospective design, and we would recommend a prospective study with a larger sample size and comparing the AAA LASIK platform with wavefront optimized and topo-guided treatment on other platforms, which would give us a better insight. Thank you.
In cases where there was a difference in the cylinder between the topo-guided, the topographic cylinder and in the manifest refraction, how did you all go about in these cases?
Sir, in MEL 90 does not have the topography modified algorithm as given in the contour of vision by Alcon. In those, we take the axis and the surface ablation calculated by the topographer.
By the topographer.
By the topographer.
So even the quantum of the cylinder is taken, even if there's a large difference between the two, you would go by the topography cylinder?
We treat the manifest axis, whatever the refraction is there, we treat that axis, but we just, the topography guided ablation is custom. It does not give us an option of choosing which refraction to fire, but we would manually entering the manifest axis, we're just adding it up with the topo guided, the data by the topographers.
So did you find any difference between recovery time?
No, sir, there was no difference.
No. So what is the rationale of your study?
So the rationale of
new study, I think. This is not a new study.
Yes, so the rationale of study is that recently the patients come to us with the demands of a topo-guided treatment, and we do not actually have data to tell them that practically there is no difference, though the thing is marketed more, but practically the visual outcomes in both the categories are same. So people who do not have this platform of topo-guided treatment, they should also have some data to actually tell that the results are practically the similar in both the groups.
The fact remains that Alcon is making a lot of publicity, and that's the reason those who are having Zeiss, they have this problem.
Yeah.
So I'm sure in AIMS also you are having this.
We have both the things in AIMS, sir.
Okay.
We have both the platforms in AIMS.
I think earlier it was not there. Now they have not.
Yeah, but for the last 4 years, both the platforms are there.
Okay.
Thank you.
Next speaker is Dr. Shreyashi Bala. She's not here? If she's not then Dr. D. Laden Raj. Dr. Raj.
Leonel.
Dr. D. Leonel Raj. Not, he's also not there. Dr. Bhupesh Singh. Is going to talk to us on toric implantable columnar lenses in post-periodoplasty pseudophakic eyes for astigmatic management.
After the lot of refractive, now we are going to slightly on the lens-based refractive procedures. So toric implantable columbal lenses in post-keratoplasty pseudophakic eyes for astigmatism management. So as a cornea surgeon, it's very difficult to see post-op good quality corneas with having 4, 5, 6 cylinders and not happy with the outcome. They don't want to wear lenses because they are old. They don't want to go for laser because it's costly, as well as it's risky for the graft survival. So the options are limited. So you have to give 6-cylinder glasses and other eyes normal 6/6. So it's difficult to balance the number also. So options are limited. So what can be done? So we have already discussed these things. So toric implantable columbal lens is one good option that I discovered recently because we are using in high myo patients. So I thought let's try in pseudophakic eyes. If all parameters are okay, like pentacam and AC depth and all are okay, why not in pseudophakic cases? So, and they are meant for sulcus implantation. So we tried using these lenses as a piggyback lens, post-keratoplasty pseudophakic eyes. So the aim was to evaluate the outcomes of toric implantable columbal lenses to correct residual astigmatism in post-keratoplasty pseudophakic patients. And we did 15 eyes in last 1 year, and AC depth was same to more than 2.8 millimeter, normal IOP, good endothelial cell count, and normal posterior segment, and all other pathologies we have excluded from our study. So this is one case that I want to show, 79-year-old male, and having corneal opacity, we did keratoplasty, and patient recovered well. Uncorrected visual acuity was best corrected, uncorrected was 660 and N10, and reflection was 2.5 with 5-cylinder. Keratometry reading was 46.9 and 52. The rest everything was normal. AC depth was slightly more, 4.56, and the rest was normal. So this was the pentacam map. You can see the K1 and K2, 46 and 52. The rest everything was normal. Pachymetry 500 micron. Then we did the same protocol, white to white measurement with sulcus on slit lamp, and it was 11.6. And we chose acryl ICL Biotech. The main reason for choosing this lens in my study is it's cheaper. So cost is another factor in India for all these cases. So it was chosen, and this was the surgery. So standard, like how we do toric IOLs, just mark the steep axis and the incisions. So you can see some sutures are still remaining, because on these sutures the patient's refraction was stable for 2 years. So that's why we have not touched it, so that, but because otherwise again it will change. So we have not removed few sutures. And this is the toric, acryl toric. Implantation is simple, and it's easy than phakic, because in phakic you have to be very careful not to touch the lens and all those things. But in pseudophakic, if you can see the capsule rim nicely, there is no issue. You can handle it with ease. You can manipulate very comfortably. And surgery is done. So at 1 month post-op, the vault was slightly on the higher side, 901 micron, but at 3 months post-op, the vault was 750. And you can see the post-op, very clear, shiny cornea, and lens nicely sitting in place. So most of our patients have completed 1 year of follow-up, and patients are really doing well and happy without glasses. All old patients, 70 years, 80 years, with no glasses, with transplant is a miracle for them. And we also did the visual function index, and the satisfaction was more than 92% in comparison to glasses, where the satisfaction score was just 50%. The uncorrected visual acuity also increased significantly in post-operative period, and the spherical occlusion significantly decreased as expected. On one patient had high IOP in post-operative period who came to normal after the standard anti-glaucoma medications. No other adverse effect was seen. And so the take-home message is, if patient is pseudophakic after keratoplasty, toric implantable columbal lenses should be considered for implantation in sulcus like a piggyback IOL. Thank you.
Thank you, Bhupesh. Very nice presentation. Just 2 questions. Why not the astigmatism was corrected by a lens, PCIOL?
No, so
because you are putting another lens in this eye. Why the first surgeon, or
Yeah,
you as a
correct.
phaco surgeon,
Yes.
corrected
No.
the astigmatism and the refractive error at the first go?
No. So, sir, most of the transplant patients are old patients, already operated somewhere, have a scar or trauma, all those cases.
So they were operated somewhere else.
All are operated somewhere else. Because otherwise,
And they had some refractive error.
otherwise, so it's standard practice is go for keratoplasty, wait for a year, then go for IOL implantation. That is the standard practice. But mostly they are pseudo-faking. That is the worst part.
And second, was the refraction stable in these patients?
Yes, so that's very important.
Because some of the video you showed had sutures.
I told
So when the sutures dissolve or somebody
So,
cuts the suture, astigmatism is going to change.
So like my protocol is to remove the sutures one by one. After 6 months, I started removing. But once the refraction becomes stable, it's not changing significantly or not changing at all, there is no need to remove the sutures because suture impose another risk of rejection, infections, and all those cases. So once refraction is stable in long-term post-op, don't remove sutures. You can leave it like that.
But that was not a columnar lens, it's a hydrophilic material.
Yeah, but they are meant for the sulcus implantation, so there is no risk. We are using phakic patient, and these are
No, you mentioned it as a columnar lens.
Yeah, columnar
This is a hydrophilic material, the lens you have used. Biotech is hydrophilic.
Hydrophilic material.
ICL is only columnar.
ICL is a different.
ICL is the
cost
only columnar.
Yeah, but the cost factor is
Yes,
another
yes.
constraint. So that's why I chose this because it's just 10,000 rupees lens. So.
Yes.
So were these,
So in some cases, I got it customized from the company side, but mostly there was 6 diopter, 5 diopter, it's available in
Readily
the
available,
inventory.
why didn't you think of a Sulcoflex instead of the...
So again, there is some issue with the availability with Sulcoflex because the radar has, I think, taken from the Delhi Eye Zone. And so we are not getting that, and cost is another factor. That's slightly costlier lens, Sulcoflex, in comparison with this lens.
Any comparison you know about between a Sulcoflex and...
So maybe that would be interesting study. In future, we can implant a few patients with Sulcoflex and then these patients, and then compare the high-order aberration. That will be a good study.
The principle basically remains the same.
It remains
It's
the same.
add-on lens.
Add-on lens. Add-on
Do
lens.
you have any complications?
So we had high IOP in one patient, maybe some retained visco, but it was too normal. One patient, I had some pigment dispersion, iris pigment dispersion, but that was not affecting the visual acuity, visual quality, so no problem so far. No interface. No.
Any other study has been done? Any idea?
So 1 or 2 case reports I have seen, but no proper studies are there. It's a new study, sir. Thank you, sir. No. Just the standard ICL calculation. You send the K1, K2 and AC depth to the company, and they will calculate and send the white to white. Same thing. Thank you. Thank you, sir.
Dr. Raghav is there? Please come. Topic is evaluation, visual outcomes after a lenticular procedure with the novel ELITA femtosecond laser system. Now, Dr. Shroff was
Yes, sir. So what he presented was the limited market release. I am going to present the results on the clinical study that was done, sir.
for a longer period.
Yes, so they were the first. These are first in world results. So thank you, judges. Good afternoon, everyone. Today I'll be talking about evaluation of visual outcomes after lenticle procedure with a new novel femtosecond laser system. I have no financial disclosures for this particular presentation. So the ELITA is the new system by Johnson & Johnson. So I am going to tell you, my slides are not moving over here. Yeah. Okay. So this has a proprietary new biconvex lenticule. Till now, the lenticules that we have, they are all plano-convex. That is, one side is a refractive cut and one is a non-refractive cut. But here we have both sides that are refractive. So that is going to be advantageous. How, I will tell you. So these are all text. I am going to describe how this translates onto a surgery. So what's happening in basically in ELITA is that we are making, the slides are not moving over here. Slides चल नहीं रही हैं. यहाँ चल रही है, वहाँ नहीं चल रही.
This platform. उधर से try करो.
Sorry. चल नहीं रहा है यहाँ पे. ठीक. Okay. Yes. So this has a biconvex lenticle, that is both the sides are refractive. So what is essentially happening is that if you look at this image on the right, you're going to see there are very small packets of energy spent from the laser, and they are spaced very close to each other. In a sense, we are making a very small spot size, that too with a very high energy, that too kept very close, that too for a very short duration of time. On the left, you can compare the ELITA, that is the yellow, with the green, that is the VisiMax, and the blue, that is the IFS. So you see, for a very short duration, we have that energy pulse. So this is all images. I'm going to show you a video. So on the left, you will see how the current lasers are. You will see these are small holes, bigger holes that are spaced well distantly. But now on the right, these are very small holes that are placed very, very close to each other. So if you see on the right, how when we are tearing it, the edges are all ragged. But on the left, once you tear this, it comes out very beautifully and the edges are very, very clean. So that's essentially how the ELITA is working. So now silk is the name of the surgery. So this is a next generation lenticule platform. Right now only lenticules are being done. We don't have intacs or any other platform for now. We do also have flaps. We are going to do myopia, that is from up to -12 diopters, and cylindrical powers up to 5 diopters. So the advantage is that once you dock, so this was Rushal also showed you, the advantage that now we have is once you dock the patient, so if you see we can center the lenticule within the docking, and also we can align it with the 0 and 180 so that we have a good cyclotoxin compensation, and also we can center the lenticule on the pupillary axis. We ask the patient to look into the center of the microscope and we mark the visual axis. So till now the platforms are not working on the visual axis, but now this is. Now this I'm going to show you now, that as the laser is working, we go into the green zone and then we can easily do a slight cyclotoxin compensation. We see the 0, 180 and we can center we just did the compensation and the lenticule can be moved. And once the laser fires, this is one of the procedures. I'm going to just go through it. This is under AIOC guidance. So once we fire the laser, it's very easy to find the planes and the lenticules. And once you see that we go in the anterior plane, you can see on the right with the AIOC that we have gone inside the anterior plane. So the advantage we get over other platforms is that because of very small spot size, the dissection is very, very smooth. And the lesser the time we spend inside the cornea, the better we are going to have results and better the corneas are going to be. This also translates onto the results. So the study was done in 2 centers. We started in 2020 January in the Center for Sight, and then 2022 Narayan Sale also joined in. So we had a total of 170 treated eyes. We did lenticle creation in both eyes with the same platform. More than 18 years old patients were included, and refraction up to -12 and cylindrical up to -6. Just take one more minute. And this is all patients were 20 by 20 or better at 6 months, and all patients were within ±0.5 of refraction within one month. And all patients were 100% 20/20 at 12-month visit. So initially the patients were being undercorrected a little bit, but then we had 2 nomogram corrections, and now patients are hitting 20/20 at 1 week post-op. 91% patients required no or little dissection. Thank you.
Did you compare with your previous attempt machine? Did you compare?
Okay, so like sir was also saying, so as of now we are under the process of doing a head-to-head trial between the Smile and the Silk. As of now, because there are lots of, I would say, ethical implications, because there are 2 different laser platforms, but now it has been submitted, and once we start doing the trials between the Silk and the laser, that will be the first trial of head-to-head between 2 lenticule platforms. The only issue right now with the Silk right now is that we are doing a very hard dock. So once we dock the eye, we have very bad subconjunctival hemorrhage for the initial few hours, which tends to increase at one day. But yes, the patient will be able to feel that the Smile eye is cleaner than the Silk eye, but visually, patients are very, very clean. We've done a comparison of the aberrations also, and there are very less induction of higher order aberrations.
Visual recovery is almost equal in both?
Yes. Both patients, of course, they are not documented, but yes, 95% of all our patients are 6/6 at 24 hours. That is the 1-day post-op. We do have 4-year follow-ups till now, that is the clinical research trials, and they are doing very, very well.
Any regression rate?
I think so it's too soon to say. Till now,
In a 4-year follow-up?
No, we don't. No, none yet, sir. There was only one patient that had a very high cylinder. That patient is expecting a -0.75 cylinder, but that was told to the patient, and yes, but otherwise the results for astigmatism till now have been immaculate, because we have the compensation of the cyclotoxin.
Thank you.
Thank you, sir.
Next is Dr. Tanmay Gupta, going to present to us on patient-reported outcomes for satisfaction and spectacle independence with blended refractive surgery?
A very good afternoon, everyone. I'm thankful to the scientific committee for this opportunity. I'll be presenting a very impressive study, probably the first in India, about the patient-reported outcomes and satisfaction and spectacle independence with blended refractive surgery. So refractive surgery encompasses any procedure that corrects a refractive error. It is well recognized that refractive surgery has significant impact on quality of life and daily work, with benefits extending beyond spectacle independence. Today, refractive surgery has evolved beyond the stereotypical laser eye surgery with the advent of technologies like femtoLASIK, SMILE, ICL, and customized RLE. In spite of all the advancements, a good anisometropic patients are deemed unfit for a single refractive procedure. High myopia and anisometropia patients may have difficulty with fusion when wearing spectacles. A common practice followed by many centers is laser vision correction for the fit eye and contact lens for the eye unfit for LASIK or PRK. Which surgical procedure will be chosen for the eyes of anisometropia patients mainly depends on the level of refractive error. Due to the limit of the patient's corneal condition, laser vision correction has historically been chosen for less than 12 diopters of myopia, while ICL is the go-to choice for the more than 12 diopters. Previous studies by Sanders, Igraci, and Kami et al. Have reported the grouping comparisons of ICL and LASIK. The current study, probably the first in India, was objectively conducted to compare the patient-reported outcome of ICL implantation in one eye and laser vision correction in the contralateral eye and investigate the long-term visual quality and stability. A retrospective study conducted at ONK Raipur from Jan 22 to September 23. A total 25 subjects who underwent ICL, phakic IOL in one eye and LASIK laser in the other, or ICL in one eye and PRK in the other were reviewed. All surgeries were performed with the same surgeon. The ICL was used care group IPCL, and the MEL-80 examer laser system was used for LASIK as well as PRK, where the optical zone was kept as 6 to 6.5 millimeter. A quality of life and patient-reported spectacle independence questionnaire was provided to patients who had undergone blended refractive surgery at 2 months of follow-up. The continuous data represented in the form of percentage and the categorical variables represented using the frequency table, where p less than 0.05 considered as statistically significant. Coming to the results, all surgeries were uneventful and no intraoperative complication was observed. Complete satisfaction level was noted in seeing the distance, recognizing faces across the street, watching television, driving a car by night, using steps, crossing the road, using public transport and employment or housework activities. While in some cases dissatisfaction was noted seeing the bright light or glare, seeing in the poor light or dim, appreciating colors and driving a car by day. Spectacle independence with blended refractive surgery was observed in almost 19, that is 76% of cases, while 6 cases, that is 24%, still needed ARC-coated glasses for glare and halos. Overall PROs and satisfaction was similar among all groups. Refractive outcome and accuracy were similar. Refractive outcome differences were not meaningful, and substantially fewer patients noticed glare and halo. No new safety concerns were reported. As we can see, almost like 52% patients said they can function comfortably without glasses or contacts all the time, whereas 48% said they can function comfortably without glasses or contacts most of the time. The satisfaction with vision without glasses or contacts was at 100%. So the different surgical methods for the correction of myopia among anisometropia patients are based on the principles of safety and efficacy. The long-term visual quality and stability of different surgical methods should be evaluated. In this study, we presented patient-reported outcome and satisfaction. No infection, pupil dilatation, or other adverse reactions were observed, suggesting that both ICL implantation and corneal laser vision correction are safe and reliable in cases with suitable indication. The visual image magnification rate and visual quality were drastically improved after blended refractive surgery. A study by Nicholas et al. Reports better quality of vision, stable refraction, high satisfaction score after 9 years in a patient treated for high myopia with one eye ICL and another eye LASIK. Another study by Roberto Zalvida et al. Reported better visual quality gains, short-term safety, and refractive stability. A study by Zunchen et al. Also demonstrated that ICL implantation and laser refractive surgery techniques are both safe and effective procedure for both myopia and suitable indication. The choice of blended refractive surgery resulted in a higher percentage of patients who were deemed unfit for laser vision correction being satisfied with near, intermediate, and distance vision. Overall, the fewer patient-reported outcome differences were not statistically significant. My few limitations were that we did not completely match the patients based on preoperative refraction and axial length. The sample size was small, and lastly, there was no evaluation of increase or decrease in high order aberrations. So my take-home message would be blended or hybrid refractive surgery is a reliable and safe method of achieving near spectacle independence in patients with high anisometropic myopia. Thank you.
You operate both eyes after how many days?
We kept a gap of 1 day.
Only 1 day?
Only 1 day, yes. Not on the same day.
Which you prefer first, ICL or LASIK?
Sorry, sir?
Which procedure you want first?
Which procedure? We usually we did the laser vision correction on the first sitting, and the second, the follow-up day, we did the ICL implantation. Because since it's an invasive procedure, we wanted to do in the modular OT, so we used to do it the second case, yeah.
How was the patient acceptance of this type of procedure?
Patient acceptance is growing since past 2 years, so patient acceptance is growing. With our own.
Because if you tell them one eye you want to do this, the other eye you want to do this. So
they definitely ask this is something really new that they are hearing. ऐसा कहीं नहीं होता है.
Is there any advantage?
There's definitely an advantage, sir. The stereopsis improves drastically. Cost is definitely a little on the higher side. With the ICL on one eye and the laser vision correction, the cost goes almost till 1 lakh rupees for a patient. But patients who are affordable, the stereopsis improves drastically for the patients who are affordable. And they're near.
Normally, we operate both ICLs ICLs are available. So
yeah, ICLs are available, but why to go for an invasive procedure when you can do the laser vision correction in that eye, if it is fit for the laser vision correction?
So both the eyes that way were fit for laser vision correction?
No.
As far as the pachymetry is concerned?
No, sir. As far as the pachymetry is concerned, as far as the corneal topography was concerned, one eye was unfit for laser vision correction, both LASIK or PRK. So we implanted ICL in that eye and we did the laser vision correction in the fit eye.
they have anisometropia and one eye is very high myopia.
No, but anisometropia doesn't mean that pachy will be different in two eyes, no?
Pachy will
axial length may differ.
But
maybe
we
more
have
than 10 in one eye and less than 10 in the other.
you are absolutely right. But with anisometropia, if even like one eye is -14 and the other eye is -7 or 8, so the residual stromal bed decreases in the patient with a high myopia. So it will go beyond 266 micron or 254 micron if we do a ablative procedure.
True, but how many cases you find like this? It's not very common.
We do a blended refractive surgery almost
How
once.
many surgeries you have done blended?
25.
In how long? In what is the duration?
14 months.
14 months. Do
14
you get
months.
so many patients?
We are getting so many patients, yeah.
Do you have any comparison between bilateral ICL and the blended vision correction?
No,
patient satisfaction goes?
no, sir. We have not done
You
that.
have never done a bilateral ICL?
No, we have done nearly 250 bilateral ICL implantations.
In a patient with anisometropia?
In a patient with anisometropia, which was like both the eyes were unfit for laser vision correction.
Oh, she has a question.
Right. As I mentioned, there was some dissatisfaction noted for patients who were working little poor or dim light, and there was a few patients with glare. So definitely the contrast is an issue. Yeah, but the binocularity improves a lot, and even there's a cosmetic correction, because otherwise, even with the high index lenses, even if you correct one eye and you give contact lenses, still the patient will not be satisfied with binocularity. So binocularity improves a lot.
Yeah, that's the logic.
We prefer to go for a non-invasive procedure if we can go for it. Yeah.
Thank you so much.
Thank you, sir.
Next speaker is Dr. Utkarsh Trivedi. Is he here? Dr. Utkarsh? Dr. Surabhi Bansal. Benigal.
She is going to talk about predictability of microkeratome LASIK, flap thickness. Are we cutting the exact?
Good afternoon, everybody. I am presenting on predictability of microkeratome LASIK flap thickness. Are we cutting the exact? So as we all know, corneal flap creation is one of the critical steps of LASIK surgery, which can either be done mechanically or using femtosecond laser. And we prefer in getting regularity and reproducibility of these flaps, as this guarantees safety of the procedure and influences the visual outcome. In our study, we use the Moria 1-use plus SBK microkeratome for flap creation. And the purpose of the study was to determine predictability and consistency of corneal flap thickness using the SBK microkeratome, wherein we studied 90 consecutive eyes undergoing LASIK surgery by a single surgeon at a single center. We included all eyes which underwent LASIK surgery as an initial refractive procedure where flap was created using either the 90 or 130 micron head, and the necessary preoperative investigations for LASIK surgery were performed. All flaps were created using the Moria SBK microkeratome, either the 90 or 130 head, which was based on the pre-op Paki, and we took 540 microns as the cutoff. Nasal hinges were created. The right eye was operated, followed by the left eye, and the same blade was used in bilateral cases. We used the manufacturer nomogram for the ring size calculation, and the examiner laser was performed using the MEL 90 machine. 1 week post-op, the ASOCT was done to measure the flap thickness using the zoom and contrast function, and the flap dimension uniformity was measured at the center, nasal and temporally along the 6 mm optical zone. So in our results, we can see that most of the patients in the 90 micron group achieved a post-operative flap thickness ranging from 110 to 119 microns. We compared if there was a correlation between the flap thickness with the age, spherical equivalence, teeth K, and the pachymetry, but we found no such correlations. So the mean corneal flap thickness in the right eye was found to be 110.84 microns and 110.32 microns in the left eye. So these were the few previous studies which have shown similar kind of results with the 19 micron head, microkeratome head. And in the 130 group, we saw that maximum patients achieved a post-operative flap thickness ranging from 135 to 140 microns. Again, no correlations were found with the flap thickness to the age, spherical equivalent, pachymetry, and steep K. The mean corneal flap thickness in the right eye was found to be 132.4 microns and 131.43 microns in the left eye. And this was a previous study which had similar kind of a study which found a corneal flap thickness of as high as 153.3 microns, which ranged from 102 to 179 microns. So to conclude, thin flaps decrease risk of corneal ectasia, help in achieving thicker residual stromal bed. The Moria 1 use plus SBK microkeratome with 190 or 130 micron blade is a safe procedure as shown in this study, in which no incomplete flaps, buttonholes, or other microkeratome related complications were found. We were able to achieve thinner and more predictable flaps. Thank you.
I think these studies have been already done. Anything new you have done?
So with the recent Evolution 3 machine of the Moria SBK, there were not many studies. Rather, there is no study wherein this simultaneously the 90 and 130 head has been compared for the flap thickness.
With the advent of thin flaps and SBK, I think complication rate has gone down tremendously.
Were these patients also offered femto option?
At our setup, we do not have femto.
You don't have. So these patients were not offered femto option. So that's a wide variation. Nearly 20 to 30 micron variation is there.
But that can be explained based on cases that mentions that 1 to 2 weeks of post-operative period, there is some amount of epithelial thickness.
Did you study epithelial thickness in all cases?
Maybe that can be
That
done
should
as
be
a
done.
subsequent study.
Why was there a more variation in the 90 micron group as compared to the 130 micron group? If you saw the 130 micron group was close to target almost, hardly a 5 micron variation what you presented, whereas the 90 micron had almost a 10 to 15 micron variation. Any reasoning for that?
Also, most of the studies have shown with the 90 head, the flap thickness has changed a lot. Either it cut very less, at close to almost 110 or as high as 120 also. But in the 130 head, always the thickness has been consistent.
Again, in the previous studies, if I remember right, the left eye thickness of the flap was much thinner as compared to what you presented. Any reason why you felt that in your, because when you're using the same blade, the second cut always cuts a thinner flap.
Yes, sir. Even we had, but it was a very minor difference. Not.
Did you increase the vacuum by 10 or so in the second eye?
No.
Then it will cut equally.
Yes.
Thank you.
And spectral microscope.
So I request the judges to note that there's a small change in the topic. The last two investigations were cancelled out because the data didn't fit in the normative when checked again. So we now compare the parameters of ocular biometry with Pentacam and IOL Master 700. It's a very simple study, and I'll tell you why we did it, though there are a number of studies comparing both. So one cannot stress more on the importance of measuring various parameters of the anterior segment like keratometry, anterior chamber depth values, wide to wide, both in terms of accuracy for post-refractive surgery, be it lens-based or laser-based, as well as in cataract surgery. So older techniques like contact ultrasound biometry had fallacy that it needed an operator-based touching of the cornea that would again vary the axial length, and newer techniques like optical biometry, being non-contact and reliable, have replaced the older methods. But a clinician currently is bombarded with multiple modalities for measuring same parameters, and we thought, let's assess if there are any similarities or if there are differences, how to go about in choosing which biometry to use. So the aim was to investigate consistency and correlation between IOL Master and Pentacam HR. Again, the objectives were to measure and compare keratometric values, corneal thickness, anterior chamber depth, and wide to wide between the above said devices. So this study included mainly 50 eyes, and the following were the exclusion criteria. So the eyes were first subjected to Pentacam HR scan, keratometry, ACD, W3W were all calculated, and then they were subjected IOL Master 700 scan. The data obtained were then analyzed using ANOVA test. So coming to anterior keratometry, it was not at all statistically significant, though it is to be noted that Pentacam values were a bit higher in comparison with the IOL Master values. Again, total keratometry, both anterior and total keratometry, had absolutely no statistical significance. Pearson analysis further showed a good correlation between the two instruments in terms of keratometric values. When we compare the other parameters, anterior chamber depth did not have statistical significance. Here, the IOL Master anterior chamber depth is calculated rather than just derived from the machine, because it calculates conventionally from the epithelium, and we had to subtract CCT from the obtained values. However, central corneal thickness and wide to wide were significantly different between both the instruments. It was central corneal thickness was more when measured with Pentacam than in IOL Master, and wide to wide were overestimated by IOL Master. So again, in terms of keratometry, there was good consistency between both, and minor differences did not mount to significant variation in IOL calculations because they were very little. Central corneal thickness, again, apart from just refraction, refractive surgeries and IOL calculations, is also important for glaucoma management, and there were significant differences when appreciated between the two instruments, more in Pentacam than in IOL Master 700. So differences in terms of anterior chamber depth were not significant at all, and wide to wide, again, mainly which is required for ICL sizing, was significantly higher in Pentacam. The differences were probably because of difference in principles of measurement, where the IOL Master considers the difference in contrast between the clear cornea and the opaque sclera, while the Pentacam uses a Schimflug imaging to perform a 3D-dimensional imaging of the anterior chamber and then calculates limbus to limbus. The conventional instrument that was known to have a very good accuracy with real-time wide to wide was OpScan 2, and that again in further studies had to be compared with the above said devices. So both the instruments had good consistency in terms of keratometric and astigmatism. Minor differences again did not matter much because they wouldn't amount to significant IOL change. And yeah, wide to wide, however, was higher in IOL Master. The reason why we did this study was a practitioner who is not in a full setup institute would have one or two instruments at max. And again, to decide which one to use for IOL and which one to use for ICL would make it difficult choice for him. For example, Pentacam, what started as a tomographer, now has become a full-fledged optical biometry. So further studies are again required to see in which cases the vaulting was proper and in which cases the IOL had better predictability. Thank you.
Thank you. Were these parameters put in any other formula to calculate the IOL power? Because some differences are there in the pachymetry and wide to wide. Barrett's And
Barrett's
many
universal
formulas
to
need white to white
white to
also
white,
to
yes.
calculate the IOL power.
Yes, sir, definitely.
So did you try calculating the IOL power with the two different calculations?
No, sir, we did not try.
Because then only it matters.
We'll-
No, if you
yes.
find out there is a difference in the IOL power in the pentacam values versus the IOL master values, then it becomes significant. No?
Yes.
One is giving 21, other is giving 21.5 or something. So then these two are different.
Thank you so much.
Thank you so much.
Next speaker is Kanika Bhardwaj.
ये भी वो दूसरे है ना कुछ. Dr. Garvita is present.
Good evening, judges.
She is not Kanika, no?
No, she is not. हाँ जी.
She is Garvita Devdas. She is Garvita Devdas.
Carry on,
Can I
please.
start? Good evening, judges. I'll start my presentation on different approaches to management on post-LASIK epithelial ingrowth, a tale of three eyes. Here I present post-LASIK epithelial ingrowth and how we managed it in 3 patients. So as we all know, PLEI is an uncommon complication that is generally asymptomatic and does not always warrant a treatment unless it is progressive. This is the first case where the patient presented to us with bilateral epithelial ingrowth. Patient was a 34-year-old male, presented with blurring of vision since 2 months. He was operated elsewhere, microkeratome assisted LASIK in 2015 with an initial refraction of 1.5 both eyes, followed by an enhancement procedure in 21 with 1.25 spherical. So both the eyes had Probst Machard grade 3 epithelial ingrowth. There was the uncorrected visual acuity was 6/9 in the right eye and 6/6 in the left eye. Plan of action for the right eye, we planned a flap lift with manual debridement, and in the left eye we planned an ND-YAG laser. So for the right eye, this is the surgical video. I'll quickly describe it. The flap was lifted very gently, and using a hockey stick, we debrided the. 1 minute. Using a hockey stick, we debrided the epithelial nests on the cornea as well as on the undersurface of the flap. And ultimately, using glue, we deposited the flap back, and a BCL was placed over it to prevent any future ingrowth. The patient has been on follow-up for almost 2 years now. He was operated in 2022, and post-op photos I have attached showing ghost areas. Patient is 6'6" both eyes. This is the ND-YAG cap which was done for the left eye. Multiple sessions were undertaken, and 0.5 millijoule of energy was delivered at each session. So the patient in the other eye was also stable as of right now. This is the third case of post-traumatic epithelial ingrowth. Patient was very happy with her LASIK for almost 15 years. Suddenly injury with nail in the right eye, presented to us with -5 cylinder in the right eye and blurring of vision. So post-operative, so on presentation, this was the picture which showed a straightened LASIK flap and invasion of epithelial cells almost growing towards the central visual axis. So for the treatment, the patient was unwilling for surgery. Instantly, we kept the patient for fluorometholone drops 4 times a day and a tapering dose, moxifloxacin and PGPG lubricant eye drop. 2 months post-op, patient has reported a stable refraction and stable clinically. So I would like to bring to light the role of ASOCT in all the 3 cases. We can see pre-op and post-op images in the first 2 cases showing reduction in epithelial ingrowth, as well as in the case 3, the epithelial nests that are formed and are stable as of right now. So conclusion, I would just like to conclude that there are various successful modalities of treatment. Careful planning should be done to check for when intervention is required. Thank you.
Yeah, thank you very much. Can YAG laser be used for higher grade of the epithelial ingrowth? Or it can be used only for a mild grade, like grade 1 or so? Because, yeah, you tell.
In our patient, it was a grade 3, Proxmarachid grade 3. It was beyond 2 mm of flap margin. So in such cases, firstly, there are 2 things to be taken care of. ND-YAG cap can cause flap melt in the future. So the energy that is given is...
you need a lot of energy also if it is a grade 3 epithelial ingrowth.
That's why we divided the sessions or delivery energy. There were 3 settings, And as I said, only 0.5 millijoule of energy was used in every shot, and care was taken that patient was followed up for almost 2 months, the initial period during the sessions were conducted. Initially, the vision was already 6/6 in the left eye, but the patient, since patient was complaining of decreased contrast sensitivities, mild blurring, especially in the scotopic vision at night, that is why we had to go for that treatment, sir. That's it. Thank you.
Thank you.
Priya and